Hello student, now we are going to discuss JG apparatus or Justa glomerular apparatus. To understand this topic, first you look at the diagram which I am drawing here. So I am drawing the Bowman's capsule followed by proximal convoluted tubules followed by descending loop of Henle. Now if you look at the diagram, how I am drawing the ascending loop of Henle will comes always in contact with that of the glomerulus, right? So this is the ascending limb of loop of Henle, that is the thick ascending limb of loop of Henle. The junction which is giving rise to DCT or distal convoluted tubules. So this junction between this TAL and DCT always remain in contact with glomerular capillary. So glomerular capillary means all of you can understand that this is the afferent arteriole forming the capillary and this is the efferent arteriole. So this is the afferent and this is the efferent arteriole. So generally we have seen the diagram in books that nephron, the glomerulus in one side and the collecting duct on other side, but that is not the actual scenario. What I am saying here that the Bowman's capsule along with the glomerular capillary always comes in contact with the TAL and DCT junction, that is the thick ascending limb of loop of Henle and DCT junctions. At this junctional point, there are certain structures. So in this area, there are certain structure which forms the JG apparatus. Getting my point? So at this junction, if I take a cross section means suppose I have started cutting from this side. So I am cutting here, then I am cutting like this. So that is a cross section that I am taking here. So whenever I am doing a cross section like this, first I will encounter this TAL DCT junction, then I will encounter this glomerular capillary, and then I will find out this Bowman's capsule. So how this structure will looks like under a cross sectional diagram that I am going to draw on your right hand side. So here on right hand side I am drawing the cross sectional view. So what I told, first I am going to get this TAL DCT junction lumen. So this is the lumen of TAL and DCT junction, thick ascending limb of loop of Henle and DCT junctions, right? Then outside this lumen, what I'm going to get? I'm going to get the glomerular capillary. Okay, so I'm drawing the glomerular capillary here, right? Okay, look at, so this is afferent arteriole reaching, then forming the glomerular capillary, and then it is forming the efferent arteriole. So this is afferent and this is efferent arteriole, and then surrounding this glomerular capillary, obviously your Bowman's capsule will be located like this, right? So in this diagram we have to find out certain structure. Okay, three structure particularly. That three structure in combination is known as JG apparatus or juxta glomerular apparatus, right? So the first structure that we have to find out in this diagram, so I'm writing here JG apparatus. What are the three components, right? Number one, JG cell, that is juxta glomerular cell. So where these cells are located? Look at the level of afferent arteriole. So arteriole means the wall of the afferent arteriole will contain thick smooth muscle layer. Some of the smooth muscles of the afferent arteriole, they modified, okay, and after modification they forms a different kind of cells which contain certain granules, and that modified smooth muscle cells of afferent arterioles are known as JG cell. Getting my point? So where they are located? Obviously they are located at the level of this afferent arteriole. So I am drawing these cells, this yellow color cell that I am drawing here, they are JG cell. So if I ask you what is JG cell, your answer will be that it is nothing but modified, okay, modified smooth muscle, okay, cells of very important afferent arteriole, right? Modified smooth muscle cells of afferent, right? This is very important, afferent arterioles, right? They are the JG cells. Now I told you modified. What kind of modification? I told you already that modification means what kind of modification is happening rather than smooth muscle, okay, that contractile apparatus, this JG cell contain granules and that those granules contain renin. So basically it contains, okay, granules, contains granules. And what is there inside these granules? Inside the granule, the renin is present. Okay, renin is present. Now, because this cell contains granules, this is the cell which is also known as the granular cell of kidney. So, this is also known as granular cell of kidney, right? So, the first thing or the first component of the JG apparatus is the JG cell. JG cell is nothing but modified smooth muscles of afferent arteriole which secrete renin. Now, how it secretes renin? What is the mechanism? That I am coming a little later. But before that, come to the second component. So, the second component of this JG apparatus is known as macular densa cell. Macular densa cell. So, now look at where the macular densa cells are located. So, again, the same diagram. The afferent arteriole, efferent arteriole and the tubular lumen, right? So, at the level of this tubular lumen, if you look at, you will get some epithelium cell. Obviously, epithelial cells will be there. Now, the epithelial cells which are in contact with this afferent and efferent arteriole, what I am saying? The epithelium cells which are in contact with afferent and efferent arteriole means I am talking about this and this, the epithelium cells which are in contact with them, they are tall columnar in nature. But if you look at the epithelium cells which are located on the other side of this lumen or other side of this tubular epithelium, they are not tall columnar, they are cuboidal in nature. So, the columnar epithelium cells of this lumen which are in contact with afferent and efferent arterioles, those cells are known as the macula densa cell, not the cells which are located on the other side. These cells are not the macula densa. Macula densa only this population of cells which are columnar in nature, which are in contact with afferent and efferent arterioles. So I am marking these cells. This is the cells which is known as the macula densa cell. So what will be the description of this cell? If I write down the description, your description will be this, like this, that it is the columnar epithelium cells in contact with afferent and efferent arteriole. Afferent and efferent arterioles. Getting my point? Okay, so they are in contact with afferent and efferent. But question is that I am saying that these are the epithelium cells of the tubular lumen. Which part of the tubules contain macula densa cell? Okay, little controversial. So what I am writing here, I will give you the evidence. Macula densa cells, they are the cells which are located in the uppermost part of the TAL. So I am writing here uppermost part of TAL, thick ascending limb of loop of Henle. So what I told at the beginning of this lecture, I told you that the thick ascending limb of loop of Henle, where it is forming the DCT, that is the area which are in contact with afferent and efferent arteriole, that is in contact with the glomerular capillary. So now you have to choose that the macula densa cells, it is the cells of TAL or DCT. What I am saying, what will be your first choice, what will be your answer? TAL. Which part of the TL? The uppermost part of the TL where it is giving rise to DCT. Right. So I'll give you the evidence. Some of the books, or you may be thinking that you have read that macula densa cell mean they are the cells of DCT. DCT is the second choice if the TAL is not given in the choices. Right. So macula densa cell, if you look at the article, they are giving description like this, that those cells, okay, in a single nephron, there is a patch of epithelium cell at the uppermost part of the TL which are around 20 in nature. Means if you count this macula densa cell, how many macula densa cells are there in one nephron? 20. So around 20 epithelium cells, they form a patch, and those patch are located in the uppermost part of the TL, which are in contact with the afferent and efferent arteriole, and those cells are known as the macula densa cell. Right. So macula densa cell, where it is located, we have also answered. Now the third question that is asked about macula densa cell is that what is the function of this macula densa cell? Macula densa cell, it is known as the chemoreceptor cells. So these are the chemosensor cells which are located within the kidney. Right. There is also a pressure sensor cell which are also located in the kidney, and that is which cell? Could you recall? So that is nothing but this JG cell. So the JG cell is known as the pressure sensor cell of kidney, and macula densa cells are known as the chemosensor cell of kidney. That's why I'm telling these two side by side. So JG cells are known as the pressure sensor cell, or it is known as the baroreceptor cells. Baroreceptor cell. Which kind of baroreceptor? Intrarenal baroreceptor cell, because pressure sensing cells are known as a baroreceptor, right? So the baroreceptor which are located in the carotid sinus aortic body, this is a systemic baroreceptor. There are certain baroreceptor which are located inside the kidney, which are nothing but the JG cells, which are known as the intrarenal baroreceptor. Similarly, the systemic chemoreceptor, they are located in the carotid body and aortic body. But here we are talking about macula densa cells, which are known as the intrarenal chemoreceptor cells. So this is nothing but intrarenal chemoreceptor cell. So now whenever chemoreceptor cells is coming up, obviously question will be that chemoreceptor means which chemical signal they can senses. So this macula densa cell, they senses the certain content inside this lumen. So if you look at this lumen, if there is presence of sodium and chloride salt, okay, this sodium and chloride salts can be sensed by this macular densa cell by some receptor which are present at the top of the cells. I'll talk about this receptor a little later. So which chemical can be sensed by this macula densa cell? Increase NaCl load at the tubular lumen. So I am writing here the macula densa cell, they senses sodium chloride load, inside the lumen, of the tubule. Now if you read Goodman-Gilman, they are saying that between the sodium and chloride is more important for this macula densa cell. So if you have to choose only one, although we have read that macula densa is a sodium sensor cell, I am not saying that there is wrong information. It can sense both sodium and chloride, but according to Goodman-Gilman, chloride is the more important substances than sodium for activation of this macula densa cell. Right? So this is all about macula densa cell, how it is sensing this sodium and chloride, and what is happening after that sensing. We are coming to that point after a little bit time, right? Okay, so this is the second component, it is the macula densa cell. Now look at the third component of this JG apparatus. The third component is known as Lassis cell. Lassis cell, right? So first of all, we have to find out where these cells are located. So now if you look at this diagram, okay, in between this tubular lumen, so this is the tubular lumen, right? And this is the afferent and efferent arteriole. In between these two structure, I can find out that there is a triangular sepet area, almost triangular sepet area is there. Okay, so in this triangular sepet area, there are certain mesangial cells. Okay, so I am drawing these cells. So these cells are the mesangial cells which are located in the triangular space between the lumen, that is the TLDCT lumen, and the afferent and efferent arteriole. These cells are known as the Lassis cell, right? These cells are known as the Lassis cell. So Lassis cell are a kind of mesangial cells, right? So there are certain mesangial cells which are located within this glomerular capillary, in between this glomerular capillary, right? So these mesangial cells which are located within this glomerular capillary, in between glomerular capillary, they are known as intraglomerular mesangial cells. They are known as intraglomerular mesangial cells. mesangial cells, right? To differentiate from this intraglomerular mesangial cells, the mesangial cells, which are nothing but the lattice cell, they are known as the extraglomerular mesangial cells because they are located outside the glomerular capillary. So that's why the common description that is given about the lattice cell in books is that it is nothing but extraglomerular mesangial cells. Okay, this is extraglomerular mesangial cells, right? So obvious question is that what is the function of this cell and why it is in JG apparatus? Why it is the third component of JG apparatus? You will understand why it is the third component of JG apparatus a little later. But for the timing, you remember that lattice cell is known as it is an anti-inflammatory. It is an anti-inflammatory cells, right? So the lattice cells, which are nothing but the extraglomerular mesangial cells, they are anti-inflammatory cells. So the third component of this JG apparatus is lattice cell. So what are the three components? JG cell, all of you know this, JG cell, macula densa cell, right, and the lattice cell. If I have to remember only one more word, then JG cell is the baroreceptor cell, macula densa is the chemoreceptor cell, and lattice cell is the anti-inflammatory cells. Lattice cell are extraglomerular mesangial cells. I told you, apart from extra, there are some intraglomerular mesangial cells also. So what is the function of these intraglomerular mesangial cells which are located in between glomerular capillary? They are responsible for regulation of GFR, glomerular filtration rate. They had certain role for regulation of the GFR. How it's regulate the GFR? If there is relaxation of this, intraglomerular mesangial cells, then what will happen? The capillary will be dilated, and that's why there will be increase in GFR. And if there is contraction, if there is contraction of these intraglomerular mesangial cells, then there will be constriction of the capillary that will reduce the GFR. This way, the intraglomerular mesangial cells is responsible for regulation of GFR. Now there is an MCQ that what are the factors that causes relaxation of these intraglomerular mesangial cells and by which it increases the GFR. You have to remember that factors like dopamine, right, very, very important. Dopamine, by causing relaxation of these intraglomerular mesangial cells, they increases renal perfusion, they increases GFR. Very, very important point. Not only that, ANP, atrial natriuretic peptide, I have already told you in the previous lecture that it's a vasodilator, so it also causes relaxation of these intraglomerular mesangial cells. Increase in CAMP, cyclic AMP inside these cells will also causes relaxation. And not only that, increase in PG, prostaglandin E2, also causes relaxation of this cell. There are various other mediators which also causes contraction of these intraglomerular mesangial cells. You may not remember those factors because their list is very long. But only 4 factors you have to remember which causes relaxation of these intraglomerular mesangial cells and it increases GFR, right? So this way you have to remember the first concept, that is the JG apparatus mean it is consist of 3 structure. Apart from this 3 structure, you also have to remember intraglomerular mesangial cells which is not part of the JG apparatus. Now our next understanding will be that how this JG cell is functioning, how it is secreting this renin, and second we are going to understand how this macula densa cell is functioning. Means what is the mechanism of action by which JG cell is secreting renin, a little more detail, right? So JG cell mechanism, right? Okay, so I'm first drawing a JG cell. Okay, so suppose this is the JG cell. Very good. So JG cell. Now the JG cell contain many G protein coupled receptor. Okay, so I'm drawing here one GPC here, G protein coupled receptor. This G protein coupled receptor is nothing but either GS or GI. GS, GI, all these things in detailed version will be discussed in endocrine physiology. But for the time being, if it is connected with the GS or GI, it will produce a second messenger which is nothing but CAMP, right? And I am drawing another GPC here, So this is also G protein coupled receptor, but this G protein coupled receptor is a GQ type. GQ type means the second messenger that it is going to produce is increase in intracellular calcium. So suppose there is increase in intracellular CAMP. What will happen? It will causes degranulation of this JG cell. What JG cell contain? JG cell contain, it contain granules, and those granules contain renin. So basically I am saying if there is increase in CAMP, it's a stimulus for secretion of renin. It's a stimulus for secretion of renin. Okay. So I'll write down this renin with a different color so that you remember it better, right? So renin. Okay. So CAMP is a stimulus for renin. What about calcium? If there is increase in calcium, what do you think? What will happen to secretion of granules? So calcium is a inhibitor of renin secretion. Oh my God. So this is something different which we have read in many other cells, that intracellular calcium means there will be movement of vesicles towards the membrane and the vesicle will degranulate. We have also seen this kind of mechanism in synapse. More calcium means more release of vesicle, but in case of JG cell this mechanism is completely different. More calcium means less amount of renin release. Very important, remember this, and this is known as calcium paradox of renin secretion. So what is this is known as? This is known as calcium paradox of renin secretion at the level of JG cell. It is a paradox. The reason of this paradox is not known, but for the timing you remember, increased CAMP means more renin secretion, increased calcium means less renin secretion. Now the question is, who will increase the CAMP? Okay, who will increase the CAMP? What are the stimulus for this G protein coupled receptor? Remember, the first and foremost important thing is that intrarenal hypotension. Whenever the blood pressure at the level of afferent arteriole, where these JG cells are located, afferent arteriole. So whenever there is intrarenal hypotension, particularly if the blood pressure is lesser than 80 millimeter of mercury at the level of afferent arteriole, that is the most potent stimulus for this JG cell for secretion of renin. That's why we know that if there is renal ischemia, if there is renal hypotension, if there is renal hypoperfusion, that is the most strongest stimulus for secretion of renin. Now, how this intrarenal hypotension is secreting renin, the exact mechanism is not known, but the proposed theory is that it acts on the GPCR receptor, which increases the CAMP, and that CAMP causes degranulation from the cell. Getting my point? So, this JG cell is basically sensing the hypotension, pressure, right? And that's why I told you the JG cell is known as the intrarenal baroreceptor. But you please remember that we have seen that the systemic baroreceptor, what is the stimulus for them? Blood pressure. But what? Increase or decrease blood pressure? Increase blood pressure, right? So this carotid sinus and aortic arch baroreceptor, they are stimulated by increase in blood pressure. But here the JG cell, they are increasing renin secretion, means they are basically stimulated when your blood pressure is lower. How much lower? Lower than 80 millimeter of mercury. Which blood pressure is more important? Obviously systemic blood pressure, but more particularly if the blood pressure is low at the level of renal artery, right? That is the most potent stimulus. Second is that any kind of sympathetic system stimulation. So stimulation of your sympathetic system or catecholamines, okay, catecholamines, all of them increases CAMP production inside the JG cell by acting on beta-1 receptor. So this JG cell contain beta-1 receptor, that is also a GPCR coupled receptor. So whenever there is increased stimulation of sympathetic system or catecholamines is increased, what will happen? CAMP will rise and renin secretion will also rise. And the third one, which act through this increased CAMP, that is nothing but prostaglandin E2 and prostaglandin I2. So this prostaglandin E2 and I2, they also increases CAMP production inside this JG cell. So all these stimuli that I have written here, they increases your renin secretion. Very, very important for your MCQ, I'm telling you, right? So now you look at the other one. So by this GPCR receptor which is increasing calcium, if someone is stimulating that GPCR receptor, then the renin secretion will be inhibited, decreased renin secretion. What is the stimulus? The important one that I have to remember here is, okay, so I'll take this color. The important one that I have to remember here is increase in angiotensin 2, right? Very, very important. So whenever there is increased angiotensin 2 level in your blood, that will causes increased calcium inside the JG cell, and that will inhibit renin secretion, right? Similarly, if there is increased adenosine triphosphate production, increased ATP, then also, okay, there will be similar kind of mechanism. And the third one, increase in adenosine will also work through the same mechanism. So whenever there is increase in adenosine, then also renin secretion will be decreased. So on this left hand side, all these three stimuli that I have written here, they decreases the renin secretion. I hope you are remembering. Here we have written the stimulus which is increasing the renin secretion, and here the angiotensin, ATP and adenosine is decreasing renin secretion. Now where from this adenosine is coming? Suddenly you are writing adenosine, sir. Okay. Adenosine is secreted by macula densa cell, that chemoreceptor. That macula densa cell secrete adenosine when, what is the stimulus for macula densa? I told you what is the stimulus for macula densa? Yes. So whenever there is increase in NaCl at the level of macula densa cell, means increase NaCl at the lumen of TAL DCT junction, this is a stimulus for adenosine production. And whenever adenosine production increases, what will happen to the renin secretion? Renin secretion decreases. So now if I ask you this question, this is an MCQ which has been asked in AIIMS PG, that what is the relationship between luminal NaCl content and renin secretion? So whenever luminal NaCl content is rising, my renin secretion is decreasing. That's why we say that NaCl, okay, has an inverse relationship. NaCl at the level of lumen has an inverse relationship with renin secretion. Very, very important concept, clearly written in Genau, so there should be no confusion here, right? So this is the mechanism by which the JG cell is working. Now I will give you an applied aspect of this JG cell mechanism so that you remember this inhibitor or stimulator in a better way. Okay, the applied one is nothing but the very common clinical scenario, okay, that is nothing but renal artery stenosis. Okay, so suppose one person is suffering from renal artery stenosis on right side. Okay, right sided renal artery stenosis, right side renal artery stenosis. Okay, so if I draw a schematic diagram, suppose this is the right sided renal artery. Okay, could you recall that it is the renal artery which is ultimately giving rise to the afferent arteriole. Okay, so the JG cell, okay, will be located at the level of afferent arteriole. Suppose this is the afferent arteriole, the renal artery is giving rise to afferent arteriole, and this is my JG cell, right? If there is a stenosis here, so there is a stenosis here, so this is the stenosis part at the level of renal artery. Okay, so this is stenosis. So obvious thing is that whenever there is a stenosis due to high resistance, the blood flow in the post-stenotic region will be lesser. So what will happen to the blood pressure at the level of afferent arteriole or in the post-stenotic region? Simply there will be decrease in blood pressure. What is the effect of this decreased blood pressure on this JG cell? I told you that hypotension, particularly the decrease in blood pressure at the level of renal artery, if it is lesser than 80, it is a potent stimulus for this JG cell. And whenever the JG cells are stimulated, what it is going to produce? It is going to produce increased amount of renin. So renin secretion will be increased. So renin secretion is very, very high at the level of afferent arteriole, and that renin will go through this glomerular capillary and then through efferent arteriole, and then it will drain at the level of renal vein. So what will happen if I measure the renin level at the renal vein? So this is nothing but renal vein Which side? Obviously, we are talking about right side. Okay, so because the renin secretion has been already increased at the level of JG cell, so if you measure the renin at the level of right renal vein, you will find out that the renin is very high at the level of right sided renal vein. Okay, fine. Okay, I think there is no problem here. Now, this increased renin, now it will enter into your systemic circulation. Obviously, from the renal vein, now it will enter in your systemic circulation. So from here, this increased renin, okay, increased renin will enter in your circulation. Okay, and whenever renin is reaching at the level of circulation, you know what it is going to do. It will act on the angiotensinogen, that will be converted into angiotensin 1, and then that will be further converted into angiotensin 2, right? So now I can understand that whenever there is increase in renin, it will leads to increased production of angiotensin 2, right? Angiotensin 2, fine. So now this increased amount of angiotensin in your systemic circulation will produces vasoconstriction, and they have additional effect, like they will stimulate the sympathetic system also. So due to this vasoconstriction, sympathetic system stimulation, high amount of angiotensin will produce hypertension. That's why the patient of renal artery stenosis will always suffer from hypertension, secondary hypertension. So what is the cause of this hypertension? Increase in angiotensin 2 in the systemic circulation. Now, this increased angiotensin is flowing through your circulation. Now, when this angiotensin is reaching at the level of renal artery on other side means now I am drawing the renal artery. I am drawing the renal artery here. Okay. So, this is the renal artery on the other side. This is renal artery of left-sided renal artery. So huge amounts of angiotensin 2 will also reach at the level of other side, that is the left side of the renal artery. Now this angiotensin 2 will ultimately reach at the level of JG cell, because I told you already that this renal artery will give rise to this afferent arteriole. So these are the JG cells of the left side, right? So whenever this high level of angiotensin 2 is reaching near to this JG cell, what is the effect of this angiotensin 2 on JG cell? It's a stimulus or inhibitor. We have just seen that increased angiotensin 2 is an inhibitor of this JG cell. You may be thinking that why not this angiotensin 2 is inhibiting the right-sided JG cell also? Answer is, which one is the most potent stimulant? Hypotension. So already there is a very low blood pressure due to stenosis. So the angiotensin 2, although it is high even at the level of the right-sided renal artery, but that angiotensin will not be able to inhibit the JG cell, because the JG cell is already stimulated by a more potent stimulus, that is the renal hypotension. So what the angiotensin is doing on the other side, it is inhibiting the JG cell. Because of the inhibition of the JG cell, what will happen to the renin production on left side? Decrease. So if I measure the renin at the level of renal vein on left side of the same subject, what I'm going to get? I'm going to get low level of renin. So now you look at, whenever there is a stenosis on one side, okay, so here in these cases, right-sided renal artery stenosis, renin level is very high on the same sided renal vein, but opposite sided renal vein renin level is low. This low is due to inhibition by high level of systemic angiotensin 2. That's why if I measure the renin in the renal vein by invasive process, and if I compare, in these cases, if I compare the renin level in right-sided, okay, and left-sided renal vein, okay, renal vein, what I am going to get? I am going to get that right-sided renal vein renin level is very high in comparison to left-sided. What is the use of this? Why you want to measure this? Okay, whenever one person is suffering from renal artery stenosis, if you are planning for surgical intervention, generally this renin is measured from the renal vein. Why? It is said that in these cases, if this ratio is greater than equal to 1.5, so you have measured the renin level from the right sided in these cases and left sided renal vein renin level. If this ratio is greater than or equal to 1.5, then it is said that the surgical intervention will give best result. Okay. It is not that if it is lower than 1.5, you should not go for surgical intervention, but the result will be best. Result will be more beneficial for the patient if the ratio is greater than equal to 1.5. This is according to research article, right? And if one person is suffering from bilateral renal artery stenosis, okay, then also you can go for this measurement of the renin at the level of renal vein. What will happen? Now, suppose you have bilateral renal artery stenosis. Which side you are going to surgically intervene? Right side or left side? Measure the renin level in both sides. More the renin level, you should intervene. You should surgically operate that side first. Okay, because I told you the reason. Okay, more renin means that is the more stenotic region. That is the more affected region. Okay, so you should surgically intervene that area first. So this way, the renal vein renin level is measured and applied for clinical patient. Right. Now we have understood about the JG cell, how it is functioning. So that's why I was telling here that please remember this important one, that the angiotensin 2 is an inhibitor for renin secretion, and intrarenal hypotension sympathetic is a stimulus for JG cell for renin secretion. Right. Now after this JG cell mechanism, now we are going to understand the mechanism which is operated at the level of macula densa cell. Okay, macula densa cell. Okay, mechanism of action, mechanism, right? So could you recall where the macula densa cells are located? They are the columnar epithelium cells. So I am drawing one columnar epithelium cell. Okay, columnar epithelium cell, right? Okay. So obviously this is the luminal side, this is the tubular lumen, okay, of the TAL. Okay, at the apical most portion of this macula densa cell, there is a transporter, and this transporter is dedicated for absorption of 3 different electrolyte: sodium, 1 molecule of sodium, 1 molecule of potassium. So 1 molecule of potassium and 2 molecule of chloride. What is this transporter? This is the famous transporter which is known as the NKCC, sodium potassium 2 chloride transporter. Right. Now you all know that this is NKCC transporter is inhibited by a particular drug which is nothing but furosemide. Right. Lasix, furosemide. So if I ask you the site of mechanism of action of Lasix, what is your answer? TAL. Why? Because it is the TL segment of the nephron which contain the NKCC transporter. So I am saying that macula densa cell contain NKCC transporter. Now I am saying macula densa cell is part of which part of the nephron? What will be the answer? TL or DCT? It is the TL. Because if it is a cells of DCT, then what will be the transporter? The transporter will be NCC, that is a sodium chloride transporter. Sodium potassium chloride transporter is not there. So that way also it is giving that after the discovery of this NKCC transporter, the scientists are 100% sure that the macula densa cells are cells of TL, thick ascending limb of leukocyte. So after the absorption of the sodium, potassium and chloride, what is going to happen? The potassium will again diffuse back at the level of lumen. Potassium will diffuse back again at the level of lumen by some channels, right? That we'll discuss later on, the name of the channel. The chloride will reabsorb from the basolateral side by a separate channel, and the sodium will also reabsorb. The sodium will also reabsorb from this basolateral side. So sodium is moving from cell to outside, reabsorption. Sodium is entering from cell to your blood. Sodium cannot go alone because you are moving the sodium from low concentration to high concentration. So you require an active transporter. And that active transporter is nothing but sodium potassium ATPase. So sodium is going out of the cell and potassium is coming back. What is the name of this transporter? We all know this is the universal transporter, that is nothing but sodium potassium ATPase. TPH pump, which are located on the basolateral membrane of the cell. Okay, basolateral membrane means these two membranes are the basolateral membrane. So whenever sodium potassium ATPase pump is working, okay, so when it will work? Okay, now look at the whole mechanism. Suppose there is huge amount of sodium and chloride at the level of lumen of this macular denser cell. So whenever there is increased sodium and increased chloride, the NKCC transporter will absorb more and more sodium, more and more chloride, more and more potassium from the lumen to the cell. Now, whenever you are absorbing more sodium, you have to throw the sodium out of the cell also. So now you are throwing this sodium out of this cell. But whenever you are throwing extra sodium out of this cell, the sodium potassium ATPase pump is working. And whenever sodium potassium ATPase pump works, we know it requires the help of energy. Energy means adenosine triphosphate molecule will be broken down. So I am writing here, sodium potassium ATPase pump will break down adenosine triphosphate into adenosine diphosphate. So now your adenosine diphosphate is produced more and more whenever your luminal sodium and chloride is higher. So more sodium chloride means the sodium potassium ATPase pump is hyperfunctioning and more adenosine diphosphate is produced. Now this adenosine diphosphate will be broken down further into adenosine monophosphate, and this adenosine monophosphate will be broken down further into adenosine. So basically what I am saying, whenever the NaCl level is very high at the level of lumen, the cell, the macular denser cell will absorb more and more sodium, more and more chloride, and there will be production of more amount of adenosine diphosphate, will be broken down to huge amount of adenosine monophosphate, which will be broken down to huge amount of adenosine. Okay, and this adenosine, now it will diffuse out of this macula densa cell. Now you recall, what is there just outside this macula densa cell? So this is the tubular lumen. We have already made this diagram. If I go back here, okay, where is my diagram? Here is my diagram. So what is there outside this macula densa cell? Look at. So this is the basolateral membrane of the macula densa cell. Okay, from here the adenosine will be released. After the release of this adenosine, the adenosine will comes in contact with this Lassis cell. Okay, and that Lassis cell are in contact with the JG cell and smooth muscle cells also. Right? Okay. So now, whenever this adenosine is released from this macula densa cell, it is coming in contact with the Lassis cell. Now this Lassis cell, they contain receptor for this adenosine, right? So the adenosine, now it is acting on this Lassis cell. Okay, what is the receptor for this adenosine? The receptor is the A1 receptor. This receptor are present on this Lassis cell. Whenever adenosine is stimulating this A1 receptor, what is going to happen? There will be influx of calcium molecule. Inside this Lassis cell, right? Calcium is entering inside this Lassis cell, right? Huge amount of calcium. Now I already told you that this Lassis cell are in contact with the smooth muscle cells of afferent arteriole, and some of the modified smooth muscle cells are converted into the JG cell. So the Lassis cell are also in contact with the JG cell. So these are the JG cell and these are the smooth muscle cells. So this is the smooth muscle cells. So Lassis cell in contact with them, and not only contact, there is presence of gap junction. So there will be gap junctional contact here. Okay, so gap junctional contact will be there. So just let me draw this. Okay, so this is the Lassis cell. Okay, and there will be presence of gap junction here. So gap junction between JG cell and Lassis cell, gap junction between smooth muscle cells and Lassis cell. So this is gap junctions. Now you know the utility of gap junction. Whenever there is presence of gap junction, the calcium which has entered inside this Lassis cell, those calcium will easily go from Lassis cell into the smooth muscle cells. So the calcium is entering from this Lassis cell into the smooth muscle cell. Not only that, the calcium is also entering inside the JG cell. Now, if there is increased amount of calcium inside the JG cell, what will happen to the renin secretion? Renin secretion will be decreased. Getting my point? So that's why I told you earlier that whenever there is increased amount of NaCl at the lumen of the TAL, that increased amount of NaCl will be sensed by macula densa cell, which is the chemoreceptor cells, and after sensing this high amount of NaCl, it is secreting adenosine. So adenosine level is huge at the level of Lassis cell. That Lassis cell is getting huge amount of calcium, and that calcium is entering in the JG cell, and that is decreasing the renin secretion, right? Now, what about the calcium which has entered inside the smooth muscle cell? So this is a smooth muscle cell, this is the smooth muscle cell. Calcium means contraction, obviously. So whenever there is huge amount of calcium influx is occurring, what will happen? This smooth muscle will go for contraction. So now I can understand two things, that increased amount of NaCl at the level of TAL lumen will causes decreased renin release and increased contraction of the smooth muscle cells of afferent arteriole. What is the utility of this whole thing? Why the body is doing like this? What is the utility of this thing? Okay, now you try to understand with the help of a example, right? Example is, suppose due to any reason, okay, your extracellular fluid volume is high, your ECF volume is high due to some blood transfusion, due to fluid transfusion, anyway, your ECF volume is high. So what will happen to your GFR in this condition? Obviously, the GFR will be high because there will be more amount of renal blood flow. Whenever your GFR is high, filtration is high, what will happen to the filtration of NaCl, sodium chloride at the level of lumen? Obviously, there will be increase in NaCl filtration. Now this high amount of sodium chloride, now it will reach at the level of TAL also. Although there will be increased amount of absorption also, but even after absorption, huge amount of NaCl is going to reach at the level of macula densa cell. And just now we have understood that whenever there is increased amount of NaCl at the level of macula densa, the macula densa cell will be stimulated by these chemicals. And what it is going to produce? It is going to produce huge amount of adenosine. So this is the mediator of the macula densa cell. Now what is the effect of this adenosine on the afferent arteriole smooth muscle? So afferent arterioles, smooth muscles, it will be contracted, and whenever the afferent arteriole smooth muscle contraction is occurring, what will happen? There will be constriction of afferent arteriole, there will be constriction of afferent arterioles. Now you tell me, if there is constriction of afferent arteriole, what will be the effect on this GFR? Constriction of the afferent arteriole means it will decrease the GFR. So now I can understand that what kind of feedback this is. Negative feedback, right? Because increase in GFR, is releasing adenosine, and that adenosine is acting at the level of afferent arteriole of the glomerulus, and because of the constriction of this afferent arteriole of the glomerulus, the GFR is normalized, GFR is decreasing. So this is a kind of feedback mechanism. The feedback mechanism is originating from here, the macula densa cell. Here is the main one. Macula densa cell is a part of the tubules. So this feedback is originating from part of tubules, renal tubules, and the feedback is acting at the level of afferent arteriole of glomerulus. So feedback is starting from tubules and it is acting at the level of afferent arteriole of glomerulus, and it's a negative feedback. That's why the name of this feedback mechanism is tubulo, glomerular, feedback mechanism. So this is the very famous tubulo-glomerular feedback mechanism, or TGF mechanism, that we have discussed in the previous class, that this is a mechanism of auto-regulation of GFR. I told you that there are two main mechanisms of auto-regulation of GFR. That is a myogenic mechanism and the tubulo-glomerular feedback mechanism. So now if I ask you which is the main cell which is responsible for this tubulo-glomerular feedback mechanism mediator, that is the macula densa cell. And what is the mediator for this tubulo-glomerular feedback mechanism? That is nothing but adenosine. Although this increased adenosine will also decrease the renin release, but it is not part of the tubulo-glomerular feedback mechanism. So this way you have to remember how the macula densa cells are functioning, and with the macula densa cell you must have to understand how the TGF or tubulo-glomerular feedback mechanism is working, right? So this is all about your JG apparatus.